A 45-year-old woman with a history of systemic lupus erythematosus comes to the physician with nausea and vomiting. 2 weeks ago, she had received a renal transplant and was started on sirolimus in addition to continuing her treatment for SLE. Her serum creatinine is measured at 1.6 milligrams per deciliter. Which of the following is the most likely cause for this patient's current condition? Choice A, damage from donor tissue T-cell activity. Choice B, preformed anti-human leukocyte antigen antibodies. Choice C, hypersensitivity reaction by CD8 positive T cells. Choice D, lupus nephritis. Or choice E, sirolimus toxicity. I'll wait 5 seconds and answer the question. So this patient has decreasing renal function several weeks after a renal transplant. And usually if you see something like this happening weeks to months after a transplant, it is indicating to you that it is an acute transplant rejection, which is a type 4 hypersensitivity reaction primarily mediated by CD4 positive and CD8 positive T cells reacting to donor antigens. So choice C, hypersensitivity reaction by CD8 positive T cells, is the correct answer. Sometimes USMLE will tell you biopsy results and ask you to figure it out from there. So in this case, it would be, you would see lymphocytes in the tissue, right? So of course, whenever we talk about hypersensitivity, we gotta make sure to separate it into basically 4 big groups, right? You have the hyperacute, you have the acute, chronic, and graft versus host disease. And for the most part, it's all about time. How long has it been since the transplant? Hyperacute, as the name suggests, is very, very fast. It's usually minutes or hours later. A classic question is that they connect the blood vessels during surgery and then immediately you see some kind of thrombosis forming or something. There have been questions before where the transplant is successful and then a couple hours later they will have various problems like decreasing renal function or whatever. But just remember that as long as you separate it by time, you should be able to identify it pretty easily, right? Because it's minutes to hours for hyperacute. And you want to know that hyperacute is because I have preformed antibodies attacking the new donor organ, essentially, which is a type 2 hypersensitivity, right? Acute is like what we have here. It's usually weeks to months later. It's usually considered a type 4 hypersensitivity, and it's caused by both CD4 and CD8 positive T cells sensitizing to the organ tissue and then attacking it. So you'll see lymphocytic infiltrate on biopsy. Chronic rejection is similar in immunologic etiology. It's also involving T cells, but it instead occurs months to years later, so way later than acute rejection. And usually it's from a long-term damage to the tissue. And in fact, a really good predictor for whether or not a patient is going to have chronic rejection is if they had acute rejection in the past. But as you might imagine, for chronic rejection, because it's a process that's happening over the long term, you're going to see something slightly different. On biopsy, you're going to see like fibrosis and stuff where it looks like the organ has been damaged over a longer period of time. Chronic rejection is technically a mixture of both type 2 and type 4 hypersensitivity, but I don't think USMLE tends to like testing on the hypersensitivity type of chronic rejection just because it's a little bit unclear, or at the very least, it's not as clean as the other ones. And finally, as I mentioned, the last category would be graft versus host disease, right? And this is slightly different in that it's caused by the immunologic cells of the donor, so you get donated T cells attacking recipient cells. So this is also technically a type 4 hypersensitivity, right? But it's using immune cells from the donor instead of the recipient. And usually you see this more in transplants involving immunologic tissue, right? Either bone marrow transplants or something like that, stem cell transplants. I don't think I've ever seen an MBME question where graft versus host disease was not precipitated by some kind of immune cell donation, such as a bone marrow transplant. They can technically happen with solid organ transplants. I just don't think I've seen it in an MBME question before. So a big part of this question is, of course, also being able to eliminate the other wrong answer choices here. So let's just move on to that as well. Choice A, damage from donor tissue T cell activity. As I already mentioned, this is describing graft versus host disease. Commonly occurs to transplants involving immune cells, bone marrow transplants, like I said. It's not impossible in this case of a renal transplant. It's just a lot less likely than an acute rejection, right? So you wouldn't pick this over acute rejection. Choice B, preformed anti-human leukocyte antigen antibodies. This is very verbose, but if you shorten human leukocyte antigen, it just says preformed anti-HLA antibodies, so that makes it pretty obvious. This would be referring to hyperacute rejection. And of course, that doesn't fit the time frame here, right? Like I said, hyperacute rejection is minutes to hours later, not a couple weeks later. Should be pretty simple. Choice D, lupus nephritis. Now, this patient does have lupus, and obviously I put that information there to kind of distract you. Now, of course, in lupus, a lot of the pathologies of lupus are occurring because of immune complex deposition, right? I mean, stuff like lupus nephritis and even stuff like the malar rash and all that stuff, that's all occurring because of immune complex deposition. So it's not impossible for it to be happening in this patient since she does have SLE, as I told you. But the idea of it happening a few weeks later after a renal transplant just seems unlikely, right? Usually lupus nephritis takes a little bit longer to develop. It's just not the best answer choice here, especially because I didn't spend a lot of the question talking about how she doesn't control her SLE very well, or I didn't give you other symptoms of her SLE or something like that to make you think that her SLE is the correct answer to go with here. Choice E, sirolimus toxicity. So that's just me testing you on some very annoying farm for immunosuppressant drugs. You should be aware that sirolimus is an mTOR inhibitor, and it decreases T cell activity. And two random bits of facts that you should know about sirolimus is that it does not decrease intracellular calcineurin. It does not cause nephrotoxicity. It's more well known for some other minor side effects like edema. It can sometimes cause pancytopenia. That's a little bit rare. But an important thing is that you know that it doesn't cause nephrotoxicity because you want to contrast sirolimus with two other drugs, cyclosporin and tacrolimus, which are both similar to sirolimus in the sense that they both decrease T cell activity, but they are calcineurin inhibitors versus sirolimus, which is not, and they are both nephrotoxic as well. Some other random things you could be aware of. Cyclosporin, in addition to causing nephrotoxicity, can cause hirsutism, hair growth, gingival hyperplasia, hypertension, hyperlipidemia. Tacrolimus binds to FKBP12, and as mentioned, it's nephrotoxic and can also increase the risk of diabetes. So bringing it back, you just gotta know the different types of transplant rejection, right? They test on these over and over and over. Hyperacute, minutes to hours later. Acute, weeks to months later. Chronic, several months to years later. And then graft versus host disease is where the donor cells attack the host. Decent chance you're gonna see at least one of these questions on your exam. I hope you found this video helpful. I'll see you in the next one.